रुबन हॉस्पिटल और BLK मैक्स सुपर स्पेशलिटी हॉस्पिटल नई दिल्ली ने बिहार में पहले लीवर ट्रांसप्लांट कार्यक्रम शुरू किया है। बदलती लाइफस्टाइल, खान पान के चलते फैटी लीवर सिरोसिस जैसे रोग तेजी से बढ़ने लगे हैं। इसी को ध्यान में रखते हुए रुबन हॉस्पिटल ने एक अग्रणी संस्था BLK मैक्स सुपर स्पेशलिटी हॉस्पिटल नई दिल्ली के सहयोग से बिहार में पहला HBP सर्जरी और लीवर ट्रांसप्लांट का कार्यक्रम शुरू किया। सीधे आपको हम दिखा रहे हैं तस्वीर हमारे होटल जहां कार्यक्रम की शुरुआत हुई है।
हम उनका भी स्वागत करना चाहेंगे। और आज बहुत कुछ सीखने का मौका होगा हम सबके लिए। जोरदार तालियां डॉक्टर पंकज के लिए। वी हैव विद अस डॉक्टर अमित सिंघाल, उनका भी स्वागत हम करना चाहेंगे फूलों के साथ। जोरदार तालियां प्लीज। डॉक्टर वैभव हमारे साथ हैं, उनका भी स्वागत हो। डॉक्टर वैभव प्लीज जॉइन अस। जोरदार तालियां डॉक्टर वैभव के लिए। वी हैव विद अस डॉक्टर अश्विन। अश्विन साहब प्लीज आए। जोरदार तालियां डॉक्टर अश्विन के लिए। We have Dr. Abhilasha with us. Dr. Abhilasha के लिए जोरदार तालियां प्लीज। एंड अब कार्यक्रम की विधिवत शुरुआत करेंगे
डॉक्टर दिलप्रीत।
हाँ डॉक्टर दिलप्रीत।
डॉक्टर अविनाश।
अच्छा,
रेडियोलॉजिस्ट अविनाश। डॉक्टर अविनाश।
दो और लोग हैं। We have with us Dr. Avinash. Avinash साहब प्लीज आए। And we have with us Dr. Dilpreet. मैम प्लीज आ जाएं। एक बार फिर से जोरदार तालियां हमारे सारे स्पीकर्स के लिए। And now to move forward, I'd ask सत्यजीत सर, आप देश पर आए और आज के इस खास दिन की शुरुआत हमारे सभी मेहमानों के स्वागत के साथ करें सर। थैंक यू वेरी मच। जोरदार तालियां डॉक्टर सत्यजीत के लिए प्लीज।
आज का दिन बड़ा महत्व का है। रुबन शुरू से इस ध्येय के लगा है बिहार में कौन सा चिकित्सा प्रणाली है, कौन सा चिकित्सा है जो अभी गैप है, जो बाकी जगह हो रहा है और अभी हमारे बिहार में नहीं है। तो हम कोशिश करते हैं कि उस गैप को हम धीरे धीरे यहाँ लाएं। उसी सिलसिला में अब बहुत पेशेंट हैं यहाँ, जो हमारे डॉक्टर बताएंगे कितने लीवर फेलियर के पेशेंट हर महीना में बिहार में है। तो उसका इलाज ट्रांसप्लांट है, जटिल है, लेकिन हम इसीलिए BLK मैक्स के साथ में हम लोग कोलैबोरेशन किए हैं कि ऐसे कुशल डॉक्टरों के साथ में करेंगे। तो मुझे बहुत खुशी है कि मैक्स से हमारे जो मेहमान नहीं करेंगे, हमारे सहयोगी डॉक्टर संजय मेहता, डॉक्टर अभिदीप, डॉक्टर नितिन, डॉक्टर लोहिया, डॉक्टर सिंघी, ये सभी आए हैं। ये हमारे अस्पताल में आके करेंगे। उसके पहले मेरे अस्पताल से जो डॉक्टर अभिलाषा हैं, जो हेप्टोबिलियरी पैंक्रियाटिक सर्जन हैं, हमारे साथ में जो गैस्ट्रोएंटरोलॉजिस्ट हैं, हेपेटोलॉजिस्ट हैं, डॉक्टर अवनीश और डॉक्टर वैभव राज, उनका स्वागत है इस मीटिंग में। हमारे यहाँ रेडियो इंटरवेंशनल रेडियोलॉजिस्ट के लिए डॉक्टर अविनाश हैं। हमारे अस्पताल में डॉक्टर दिलप्रीत हैं, जिनको एक्सपीरियंस है 3 साल का लिवर ट्रांसप्लांट, पोस्ट ट्रांसप्लांट इंटेंसिव केयर का। तो हमने एक ग्रुप बनाया है। हमारे नर्सेज जो पहले से ट्रांसप्लांट कर रहे हैं, रीनल ट्रांसप्लांट, उन लोगों को अब हम लोग भेज रहे हैं BLK में, जहां इनको ट्रेनिंग दिया जाएगा कि वो एक साथ काम करेंगे, एक दोनों टीम के बीच में सामंजस्य होगा। और हम लोग जब भी केस होगा, ऑपरेशन होगा, तो BLK के पूरा टीम हमारे साथ आएंगे और यहाँ ऑपरेट करेंगे। जब तक पेशेंट स्टेबल नहीं है, उनके मेन इंटरवेंशनिस्ट और उनके जो ICU के नर्स हैं, हमारे ICU के नर्स हमारे इंटरवेंशनिस्ट के साथ में रहेंगे, जिससे हम लोग एक्सपीरियंस गेन हो। तो ये एक बहुत बड़ा कदम है। हम सभी हमारे डॉक्टर सहयोगी जो आए हैं, उनको डॉक्टर मिस्टर मिधा जो हमारे साथ में तालमेल, लोगों को अवेयर करने के लिए, बिहार में इस बात को अवेयर करने के लिए हमारे टीम के साथ में काम कर रहे हैं, उनका भी बहुत स्वागत है। स्वागत है हमारे दोस्तों को, मित्रों को जो आज आए हैं हमारे बात को समझने के लिए। और यही है जो इनके पास पेशेंट आएंगे, इनका पेशेंट जिसको ज़रूरत होगा वो हमारे हॉस्पिटल में या किसी भी सेंटर में जहां ट्रांसप्लांट हो रहा है, तो हम इनके थ्रू मरीज के पास में हम पहुंचेंगे कि अब पॉसिबल है कि पटना में ट्रांसप्लांट हो सकता है। ट्रांसप्लांट, देखिए, एक जो इलाज है वो अच्छा इलाज सारे दुनिया में एक होना चाहिए, पटना हो, बॉम्बे हो, दिल्ली हो, इंग्लैंड हो, अमेरिका हो। क्वेश्चन है कि हम पहला एफोर्डेबिलिटी, दूसरा एक्सपर्टीज। तो एक्सपर्टीज तो हम लोग मिलके ला रहे हैं और हम लोग दिल्ली से हम लोग कम पैसे में करेंगे। और हम बात कर चुके हैं हेल्थ डिपार्टमेंट में भी कि वो लोग अभी भी हमारे अस्पताल में ओपन हार्ट सर्जरी, किडनी ट्रांसप्लांट, कैंसर का ऑपरेशन होता है तो CM फंड से और PM फंड से मिलता है, तो उनका भी सहयोग रहेगा। तो इस तरह से हम लोग चाहेंगे कि बिहार के लोगों का एफोर्डेबिलिटी जो हो उसके ही तहत में हम लोग करें और आगे फिर हम लोग इस बात को बढ़ाएंगे। तो आपको सभी को आने के लिए बहुत बहुत धन्यवाद। हम इस कार्यक्रम को और आगे बढ़ाएंगे। नमस्ते।
Thank you very much, sir. And now we'll move forward for the technical sessions. तो सबसे पहले लिवर ट्रांसप्लांट और करंट एंड प्रोस्पेक्टिव जर्नी, इस पर बात करने के लिए जो स्पीकर्स हैं, उनसे पहले हम चाहेंगे कि डॉक्टर सौरभ जायसवाल एंड डॉक्टर अवनीश कुमार इस सेशन को चेयर करें। प्लीज डॉक्टर सौरभ जायसवाल एंड डॉक्टर अवनीश कुमार, जोरदार तालियां प्लीज हमारे चेयर करेंगे। Now, our first speaker is one of the most accomplished and proficient surgeons in surgical gastroenterology and liver transplantation in India. 18 साल से ज्यादा का अनुभव उनका है और अपने आप में बहुत बड़ा नाम, 1250 से ज्यादा सक्सेसफुल लिवर ट्रांसप्लांट कर चुके हैं। ये सीनियर डायरेक्टर एंड HOD हैं BLK मैक्स में। प्लीज वेलकम डॉक्टर अभिदी चौधरी। जोरदार तालियां के लिए।
Good evening, everyone. Thank you, Umang sir, for the introduction. And you rightly said कि जिगर को लेके बहुत confusions रहती हैं और बहुत सारी confusions बॉलीवुड मूवीज क्रिएट करती हैं। जब वो एक्शंस में जिगर हार्ट की तरफ चला जाता है तो confusion अक्सर हो ही जाती है। But good, it's a medico gathering and people know what jigar is and where jigar is, so it is easy to explain. And rightly, as you have created the background, so liver disease, as we all practicing gastroenterologists, hepatologists will tell you, there is a great burden of liver disease. So before I go to liver transplant, I just want to highlight the overall burden of liver disease and what status are we in India in this scenario. So this is one of the publications from WHO which actually took into account liver disease related mortality. If I can have a pointer, that will help me. So liver disease related mortality in 187 countries throughout the world. And if we look at this number, and that's okay, I'll use this. So if we look at this number, total deaths from liver disease is increasing throughout the world. And various parts of the world has high, and India is basically, we look at around 20 deaths per lakh population. But this is just the mortality. So going further in this article took into account the data that came from hospital-based death. That's the government data. And according to that data, 2 lakh Indians die every year because of liver disease. And mind you, most of these lives can be salvaged by proper intervention and proper treatment. And basically we are such a big population, so we account for like 20% of the liver-related deaths in the world from India. Now, the most common causes in Indian scenario still is alcohol-related liver disease against the Western world, where it is viral hepatitis and NASH. Whereas the incidence of NASH is also rapidly increasing in India. So it looks like in coming decade, we'll see NASH as the most common cause of liver disease in India as well. And the common reasons, as we all know, is multifocal and metabolic disease. Pediatric age group is no exception. Even in the pediatric age group, there is a significant burden of liver disease. That's the ICMR data, which actually they looked at kids in the school, and they found out that approximately 8 to 80% of the overweight kids have some kind of fatty liver. And this is the population when we look at when they're going to grow old, or they're going to be young adults, they're going to be having NASH-related liver disease, which is going to increase over a period of time. If someone can look at the surrounding sound, that will be easy for me. And so we need to look at all these aspects, because this age group is something which is going to be the burden for liver disease. So, but what happens is, I'm glad on my background there is some bhajan and shlok going on, so you can enjoy both at the same time. So most of the patients are diagnosed by the time they already have liver failure, and I'm sure this shlok will help them to get treated. Otherwise we are going to help them with liver transplant. So, and as far as liver transplant is concerned, it's actually a story of remarkable achievements. So liver transplant actually started in 1960s, where initial 10 years were all experimental. But by 1980s, we started to get some good success. If you look at the history of liver transplant in India, so initial DDLT happened in 90s, but the successful transplant happened in 98. I don't know whether you're going to listen to me or that shlok again, but still I'll continue with my slides. So in the initial 7-8 years, only 130 transplants were done with almost 60% success. But over last 15 years, the numbers have increased rapidly, and now we are doing around close to 2,000 to 2,500 transplants in this country, which accounts for very less number compared to the decently developed countries. Because, as I said, we lose approximately 2 lakh people in this country. Ideally, all these patients can be salvaged with liver transplant. But if we statistically look at the situation that we are underdeveloped country and we still lack resources, and there are a lot of people who can't understand and afford transplant. So stats say at least 10 to 15% of this burden should get transplant. So we should be doing around 30,000 transplants in this country, whereas we are doing only 1,800 to 2,000 transplants in this country. And if we look at all the scenarios and we start working on minimizing the organ shortage and creating an awareness about liver disease and timely treating these patients, a lot of these lives can be saved. Now, once we know someone has a liver disease, not all patients with liver disease needs liver transplant. There is a selected group of patients with liver disease who need liver transplants. It's basically people who have liver failure, that means a decompensated liver disease, who have a MELD score of more than 15 or a child B or C status. Some selective acute liver failure patients, selected group of liver cancer patients, and some pediatric patients who with metabolic liver disease or biliary atresia would require liver transplant. So this is a summary of the guidelines from various associations in the world which talk about any liver cirrhotic patient who have complicated ascites, who have hepatic encephalopathy, recurrent bleeding, hepatorenal syndrome, or any of these major complications should undergo transplant. In pediatric age group, we don't wait for these complications to happen because we have to make sure the child has to survive as well as the child has to grow normally. So as soon as there is a deviation from the normal growth pattern, that is the time we suggest transplant. Now, a situation where we have decided a patient needs transplant, the next question comes is where the liver is going to come from. So there are two ways we can transplant. One is transplanting a liver from a brain dead donor or taking a liver from a living donor. Now, the brain dead donation is pretty less in India, although southern part of India has matured and there is a significant improvement in organ donation in southern part of India, but north, west and east there is hardly any donation and we have to rely basically on live donor transplant. So as far as live donor transplant is concerned, anyone who is a family member, healthy, fit mentally and physically can donate part of the liver. The beauty about the liver is you can remove up to 75% of the liver and the rest of the liver regenerates back to full size. So practically you can say in 6 weeks to 3 months there will be 2 liver out of 1 when we do a live donor transplant. So whenever we select someone as a donor from the family, we do a detailed evaluation. So the donor goes through detailed medical evaluation, surgical or radiologic evaluation and psychological evaluation. And every single donor is reviewed by a board, a medical board which includes cardiologist, chest physician, anesthetist, psychologist, psychiatrist, gynecologist, at times other specialties depending on what the requirement is. Once the donor is cleared by this medical board, then the case is sent to the legal board, which is the state appointed authorization board, which independently assesses the scenario that there is no coercion, there is no jabardasti happening for the donor, and once they clear legally, then only you can do the transplant. By doing this evaluation, as a surgeon, we do a graft planning and decide how much liver we are going to take out from the donor, whether that amount of liver is adequate for the recipient or not. And when we are doing for small babies, we have to make sure that liver should not be too big for the baby's belly. So as we know, liver is like 8 segments packed in one. So earlier we used to take either the right or the left lobe. Now we can take pretty much any part of the lobe. We can take part of the right lobe, part of the left lateral. So small babies, when we take maybe one segment of the liver, which is a monosegment graft, about which I'll just mention. Once the split liver is taken out, it is prepared to be implanted in the patient's body by using artificial grafts. And then it goes through various anastomosis, outflow, inflow, and after that this is how the liver looks after the implantation. So as far as once the surgery is done, the most common question that people ask is what is the overall success of the transplant? So this is the worldwide data, and these days that success is measured in terms of long-term survival. So these days we talk about more than 90% 1 year and more than 80% 10-year survival after liver transplant. If you calculate both adult and pediatric. Pediatric transplant have a slightly better survival because kids have a better recovery after transplantation. So donors are usually discharged after 7 days of the surgery and they resume their work after 3 to 4 weeks. The patients can go back to their normal life after 3 months. They can go back to their job and do their normal course, and they usually live like a normal individual. Only thing they have to make sure that they take their immunosuppression well. One important thing about recipients I want to highlight, because they are on immunosuppression, they have a slightly high chances of developing metabolic disease like diabetes, hypertension, dyslipidemia, osteoporosis. So whenever these patients are being followed up by any physician, I suggest them to make sure all these parameters are checked whenever a follow-up is done. So if a patient maintains these immunosuppression and the good follow-up, they live like normal people after the transplant. So this is about the regular transplant and what newer things which we are doing over last 5 to 10 years I would just want to highlight. So earlier whenever we used to do transplant, we used to make sure the patient and donor blood group is compatible. But over last decade, there has been a significant progress in terms of ABO incompatible transplant. There are a lot of families where there is no blood group compatible donor in the family, where we select the patients where we can do ABO incompatible transplant based on what antibody titers are there in their blood. And what we do is we remove those existing antibodies and make sure the new antibodies do not form by using certain mechanisms, like giving injections like rituximab and doing immunoabsorption plasmapheresis. These days we have super selective filters which target the antibodies we need to remove. Suppose we are taking a donor for a O recipient, we can use a super selective anti-A filter which just removes the anti-A antibody and makes the transplant compatible. The overall success by doing these things, this is our departmental protocol published in various textbooks. So by using that, we have successfully done more than 30 transplants by ABO incompatible transplant. Now portal vein thrombus, extensive portal vein thrombus, this is one of the complications of liver cirrhosis. And whenever extensive portal vein thrombus used to happen, in earlier days we used to do a multivisceral transplant where we replace both liver and intestine. These days by various surgical techniques, we can only do liver transplant and we do certain jump grafts, like in this one we use artificial graft to take blood directly from SME or splenic vein, and sometimes if none of this is available, then we take a flow from renal vein or augment the flow using these kind of grafts. And there are certain situations when the patient is very big and the family donors are small in size. One donor cannot give adequate size of the liver to the recipient. In those situations, what we do is dual lobe living donor transplant, where we select two donors, take small part of liver from two donors and we implant two livers in patient body. Technically very complex, but in selected situation it does wonder because it keeps the donor safety intact and helps the patient recover faster because the patient gets adequate amount of the liver. A minimum liver mass is required for it to regenerate and to make sure the patient recovers after the transplant. Now there are certain situations where not just the liver but all the blood vessels around the liver are also damaged, like IVC is damaged, portal vein is damaged. In that kind of situation, what we do is, in this kid, what we did was we opened the heart and made a new anastomosis from heart to the inferior vena cava below the renal veins and implanted the renal veins and the liver. So it is kind of reimplanting the kidneys and the liver in these kind of situations. So as I was mentioning, in kids, the problem is not the less amount of the liver, the problem is the more amount of the liver. However small liver you take, it sometimes is too big for the baby's belly. Whenever we are doing transplant for small babies which are like 4.5 kgs, even if we are taking only small left lateral lobe, it is too big. Earlier days what we used to do was we used to just put a Bogota bag and wait for that liver to shrink and then close only the skin, and when they used to grow, we used to do hernia repairs. But these days what we do is we take either a monosegment graft or hyper reduce the liver. It is like liver ko tarashna, itna chota kar lena ki you can fit in the patient's body. And this is done with the help of our intervention radiologists who help us mark where the major blood vessels are, and you can actually split that liver and put it easily in patient's body, which helps these babies recover much faster. Now there are certain situations where it is not just the liver, the kidney is also affected, or the situations like hyperoxaluria where there is deficiency of enzyme in the liver which is causing the kidneys to fail. In those kind of situations, what we need to do is a combined liver-kidney transplant. There are situations like patients who are on dialysis, they get hepatitis B or C during their dialysis period, which lead to their liver failure as well. So in these situations, what we do is combine liver-kidney transplant. These days, as we were discussing in the morning, we have switched our donor surgery to minimal invasive donor surgery using lab, and recently we have started doing robotic donor surgery, which has helped us in reducing the scar significantly, and these days we are taking out the midline. The idea is to finally shift to the phalansteal incision so that the scar would not be visible. Now with all these surgical techniques of living donor transplant, The another advantage which has happened for patients with liver cancer and biliary cancer, hypercholangios, CAGBs is the situations where there is involvement of the blood vessels, which at one point of time was contraindication for surgery. These days we re-implant those vessels by dividing the vessels, which help us in getting a complete R0 clearance. So this is not just us, most of the live donor liver transplant centers have improved their outcomes of surgeries for patients with cancers like biliary and HCCs, and where they require vascular, both artery and portal vein reconstruction. It is like auto transplant. You just remove the part of that tumor with the liver and re-implant the remnant liver, which helps us in giving much better outcomes. So a little bit about our journey, how we have developed over a period of time. So we started as a team in 2012, and over last 10 years, we have actually treated patients from almost 40 countries, almost all continents in the world. And during this period, we have done more than 1,500 transplants and HPB surgeries. During this period, we have actually set up many transplant programs, one in Bangalore, Pune, and 2 international programs. We help their teams to get trained. During this period, we have published around 23 articles and 9 book chapters. This is a milestone which we achieved some time back and which was celebrated in the hospital. So these days we are doing around 20 transplants every month. We are running one of the most successful ABO incompatible transplant. Our protocol is well published in transplant textbooks. We're doing great numbers of pediatric transplant and a complex HPV surgery. And all this is possible because of the great team we have, which includes a surgical, not just the surgical team, but a strong anesthesia, critical care, infection control, most strong intervention radiology, and our nursing and coordinator team. And this is the most important thing I feel. When the whole team tries, then only we fly. And I would want to invite my core team members who are here so that I can introduce you. They are the backbones of the program. I would want to invite Dr. Nitin, Dr. Pankaj, and Dr. Amit to the dais, please. We could not bring the entire team for obvious reasons because the work is still going on there. So only the core members could come, and these kind of things require a very strong team and a dedicated 24/7 coverage. So we always have 2 consultants who are there in the hospital full time, a dedicated team of 70 plus people, including our nursing, OT staff, coordinators, intervention radiologists, hepatologists, other than anesthesia, critical care, and surgeons. So with all this, we could, our rare cases were published in various journals and newspapers, and our unit was awarded at multiple times. And these are some happy patients. I just wanted to share their pictures, and these are the patients who give us a proud moment. And last, I would want to talk about organ donation, and this is something we as a learned society have to work together to make sure India is considered as one of the best destinations for liver transplant. We should be known for the best transplant practices, which include both live donor and cadaver transplant, because as I said, with the NASH population increasing, we'll not have donors in the family. And if we don't work on increasing cadaver or brain dead donation in every single state, every single city of the country, we'll have problems for the next generation. And if we don't do it, our next generation will not spare us. Thanks a lot.
If anyone has a question, you can ask. Anyone, any question? Okay. Then I'll move to our second speaker, जो हमारी अपनी धरती से हैं, पटना से ही हैं, son of soil, 12 साल से ज़्यादा का अनुभव है, and बहुत सारे पेशेंट्स को सक्सेसफुली उन्होंने ट्रीट किया है और हमारे बीच यहाँ पर हैं. प्लीज वेलकम डॉक्टर नितिन, जोरदार तालियों के साथ सर प्लीज आए. ये बाइक यूज कर सकते हैं.
Thank you very much. Good evening, all of you. My dear colleagues, teachers, distinguished members. I am from Patna, and I did my MS from Darbhanga Medical College. I am mentioning it first deliberately because my external examiner is sitting here, and it's really a great moment for me. And then I moved to Delhi, and then I joined the Institute of Liver and Biliary Sciences there. And I did my MCS there, and after MCS, I have been associated with Dr. Abhidhi. So, important thing in any journey is the leadership. And that leadership was given by the Dr. Abhidhi to us, and that is why we are here today. And then, when we achieved many things there, then I discussed with Sir one day, what good is the training if I cannot give back to my own people? Then he said, okay, let's try something. And then we decided that we'll do OPD in Patna. We tried many things. Then we got associated with Ruben Hospital since 2020. Then the COVID came and everything happened, but I continued to attend the OPDs as and when it was possible. And then one fine day, I discussed with Dr. Satyajit also that how can we take this forward and make it a viable program here. And he said, why not to do it here? And our new hospital is coming up. And then he took me to the new hospital. He got me to the rounds and showed me that these are the infrastructures here. Is it possible to do it here? I saw it. I said, yes, sir. Possibly we can do it here. Then I discussed back, and then the lot of discussions, and after everything, we have reached to a stage today where we are launching this program in Bihar and Patna in Ruben Memorial Hospital. So, liver transplant is a very complicated surgery. It has its own complications, and when you do transplant in any hospital, you have to raise the bar a little bit. Whatever you are doing till now, you have to increase the quality of the things, expertise, training, everything, and it's a multidisciplinary approach. So it's not about a single specialty or a surgeon or an anesthetist or critical care. All of us has to work together. And when patient has any problem, then the cardiologist, neurologist, neurosurgeons, intervention radiologist, everyone is called into, and it's a very concerted effort. Everyone needs to put in their best effort to get the best results. It takes time, but as we have reached to this stage where we are giving one of the best results in the world, and we are better than the benchmark. The world literature says that liver transplant has 10 to 15% mortality, but our mortality rate is around 5 to 6%. So we are doing better than that. Now we are working to reduce it further. We want our next 100 transplant to be without mortality. So we can reach to that heights even in this place also if we work together, and that will help to improve the general condition of healthcare in the Bihar further. Thank you very much.
थैंक यू वेरी मच सर। और मैं चाहूंगा हमारे डॉक्टर सौरभ और डॉक्टर उन्नीस से भी इस सेशन को समाप्त करें प्लीज।
Thank you everyone. Actually, liver transplant is one of the most important part in gastroenterology and hematology department, because we have so many patients dealing with chronic liver disease, acute liver failure, and the pediatric population also dealing with the liver diseases that require liver transplant, but we don't have the facility to serve them. So that is a very good opportunity for Bihar, that Ruben Group have initiated this program to serve our people in Bihar only. And I would like to thank Satish sir to give us this opportunity to serve our people for liver transplant and take this step to another level.
यू वेरी मच। और हम चाहेंगे सतीश सर को एक बार।
Hello. So I would just like to point out two things. First, to emphasize about the timeline. So the world did its first transplant in 1960s. India did in 1998. So we were 30 years behind the world benchmark. And India did in 1998. In Bihar, it is 2022. We are already 25 years behind that landmark. So we have to catch up. That is one point. The second thing, there is technical factors and then there are non-technical factors. So technical factors, there the best team is there. So we don't have to worry about that. The non-technical factor, it is about two things. The late referrals, here the awareness is the main point. In general, in India we see that patient gets very late referral for liver transplant. Even in the best centers in India, the referral point is very late. So that will improve only by making awareness among the physicians. We, the physicians, have to refer the patients for transplant at the adequate time. And the second point is the economics part. From the world standard, we have 1/10 of the cost. So that suits the Western population. They come here and get the transplant done. But from Indian perspective, even that 1/10 the cost is too much for us. No average person can afford 20 lakh, 25 lakh rupees of money. So though we are doing at 1/10 of the world cost, but from Indian perspective it is too much. So how to cater to that part? As Satyadeep sir said, that PM fund is there, CM fund is there. And the non-technical part, that is for the awareness of you all, that how to refer the patient at adequate time. And the third and the last thing, as Abhijit sir just rightly told, that as we are doing live donor transplant, and NASH is the most common etiology which is causing CLD. So the whole family members are suffering from fatty liver disease. So suppose I get end-stage liver disease, my son will also be a fatty liver, my daughter will be a fatty liver. So who is going to be the donor? So that part also has to be worked upon as a general society awareness that people don't get fat. So I will just end with these 3 points. Thank you.
थैंक यू वेरी मच सर। और अब मैं चाहूंगा डॉक्टर सतीश प्लीज आप आके एक स्मृति चिन्ह को भेंट करें। जोरदार तालियां का फिर से सबके लिए। मैं सबसे रिक्वेस्ट करूंगा एक ग्रुप फोटो के लिए सर। अब सब आए। थैंक यू वेरी मच सर। प्लीज अब हम अपने दूसरे सेशन की तरफ चलते हैं। The second session is on the scope of liver transplant in Bihar. और इस सेशन को चेयर करने के लिए मैं आगे बढ़ूंगा डॉक्टर विपिन से, कार्डियोलॉजिस्ट है रूरल हॉस्पिटल से। डॉक्टर विपिन सर प्लीज आप आ जाएं, और साथ ही डॉक्टर पंकज जोगिया, इंटेंसिविस्ट रियली थोड़ा टफ ये सब टर्मिनोलॉजीज होगी। So please welcome Dr. Pankaj and Dr. Vipin to chair the session. Our next speaker is Dr. Vaibhav Raj. एक दशक से ज्यादा का उनका अनुभव रहा है और गैस्ट्रोएंटेरोलॉजी और हेपेटोलॉजी के फील्ड में काफी बड़ा योगदान। एक्टिव पैनलिस्ट हैं, बहुत सारे कॉन्फ्रेंसेस में उन्होंने पार्टिसिपेट किया है। ही इज मेंबर ऑफ इंटरनेशनल लिवर ट्रांसप्लांट सोसाइटी एंड आल्सो मेंबर ऑफ अमेरिकन कॉलेज ऑफ गैस्ट्रोएंटेरोलॉजी। प्लीज वेलकम डॉक्टर वैभव राज प्लीज।
Good evening, everyone, respected teachers, my seniors, my colleagues. I'm a bit of a newcomer among the doyens who are sitting over here. I have completed my hepatology 2 years back from IPA of Kolkata, and I have actively participated in the liver transplant process of around 30-35 patients, of which we have outcome of around 85% survival. So after that I came to my hometown Patna and I joined with the Ruben group, where I have been actively working for the benefit of the patients of liver disease at Ruben Memorial Hospital. So first coming to the part of this scope of liver transplant in Bihar, as we all know that Bihar has not been able to do successful liver transplant till now, as Dr. Saurabh Jaswal already told that we are very much lagging behind, almost 25 years lagging behind among the top colleges, top places of India like BLK, Max or other institutions where they are actively doing liver transplantation. So coming to, can you please see the slide? First coming to introduction of liver transplant, I think most of the part has been dealt with previously. I will just brush up the few things. It was first successful liver transplant was conducted in 1963, and in India it was first conducted in 1998. It was a case of pediatrics, biliary atresia. It was a successful transplant, and it has gradually evolved rapidly in India. And presently we are doing around 2,000 to 2,500 liver transplant per year, and survival is around 95% at 1 year, 76% at 5 years, and 71% at 10 years. And this improvement in success is because of these new immunosuppressants, new preservation solutions. Then we have new improved surgical techniques and improved surgical techniques. We have early diagnosis and management of complications post liver transplantation. So so what are the candidates for liver transplantation? I've already explained that the timing of liver transplant is crucial because we need to we need to make the physicians aware that when they have to send the patients of liver disease to a referral center or to a gastroenterologist or a hepatologist before any life-threatening complications occur. And also it should not be done very early so that the risk of surgery outweighs the risk of immunosuppressions. So priority of liver transplant is based on child health and MELD score, in which we actually calculate MELD score on the basis of creatinine, bilirubin and INR. If it is more than 14, then we can consider the patients for liver transplantation. Or if the build is very high, that is, if it is more than 35, then maybe that we will have a very not very good outcome as compared to patients in which we are doing transplant between build 15 and 35. We have actually a computer score on which we detect this. And this we have, we also have other points in which we use exceptions to build score if we have refractory complications of cirrhosis, like if we have refractory ascites or GI bleed or recurrent leukocytopathy, hepatopulmonary, portopulmonary or intractable pruritus like in PFIC. Or we have other diseases like Budd-Chiari or familial hemolytic polyneuropathies or cystic fibrosis likewise. Or we have malignancy, then we have to skip this build score. So this burden of liver disease globally, coming to globally, accounts for approximately 2 million deaths per year worldwide, in which 1 million is mainly because of cirrhosis and the other 1 million is due to hepatocellular carcinoma and viral hepatitis leading to acute liver failure. And cirrhosis, it is the 11th most common cause of death globally, and liver cancer is the 16th most leading cause of death. Combined, they account for around 3.5% of the death worldwide. And cirrhosis is within the top 20 cause of disability adjusted life years in years of life lost. So coming to burden of liver disease in India. In India presently, most common cause of this liver disease is still viral hepatitis, that is hepatitis B and C, but in coming trends, in coming years, we are seeing that the NAS related liver disease is coming to the forefront, and it is also causing a very large fraction of people with liver disease. And coming to Bihar, in Bihar we have around 6 million population who are chronically infected with either hepatitis B or C. And in India we have around 40 million people who are chronically infected with hepatitis B, and we have around 10 million populations who are infected with hepatitis C. And this chronic hepatitis B accounts for majority of the HCC, 40% of HCC and 20-30% cause of cirrhosis in India, and HCV accounts for approximately 12 to 32% of hepatocellular carcinoma and around 20% of cirrhosis. So this is the epidemiology of liver disease. In the coming, we can see that we have this acute hepatitis. We have acute hepatitis, we have liver cancer, we have liver cirrhosis, and it is around coming to liver cirrhosis. It has gradually increasing. The death per million population is around 200. Coming to burden of liver disease in India, and from one of the survey which I collected, it is around the number of added cases, that the number of incidents of this acute hepatitis B or C in 2016 was around 1.5 lakhs, in which Bihar it was around 30,000. Again 2017 it was around 1.6 lakhs, in which Bihar accounted for around 24,000 cases, and 2018 it was around 1.5, and Bihar contributed around 5,000 cases with a case fatality rate of 0.5%. So actually we have a meager of data from Bihar in which what is the incidence, what is the prevalence, what is the mortality of patients because of liver disease. It is a bit meager. We don't have very much systematized data from Bihar. In our setup, which I have collected from January 2021 till March 2022, I would say that there was a COVID time. So this is mainly reflected in the last 6 to 8 months, which we have seen. In OPD of GI OPD, we had 6,771 patients. Of which liver disease patients, that is of cirrhosis patients, was around 550. In which many patients were in the early stage of liver disease, many were in the advanced stage of liver disease. And GI IPD, we had around 1,000 admissions, of which patients of cirrhosis and liver disease were, acute liver disease were around 165. And among those patients, potential candidates for liver transplant was 75. I calculated in our basis of MED score, as I told that MED score more than 40, we can consider for liver transplantation. So we can see that there is so much of burden of liver transplantation, need for liver transplantation in the Bihar population. There is in one institution, that is one hospital, we have so much cases. Coming that, we can say that in 1 month we have around 10 cases who are potential candidates for liver transplantation. And we counsel the patients for liver transplantation, but because of many factors like cost, lack of awareness, they are afraid to go outside of the state, and many things are coming to play which leads to failure of the patients to get counseled and go for liver transplantation. And because of that, we are losing every month around 2 to 3 patients in our setup. They are dying of the complications of liver cirrhosis. And many patients go to other centers, many patients go outside of the country, but they go very late. We refer the patient, but they go very late because there is a lack of awareness. So, in Bihar, we have definitely a very big load of patients of chronic liver disease who are potential candidates for transplantation, and they need to be counseled. And so, what are the nodal points for success of liver transplant in Bihar? Definitely 20 to 25 lakhs amount for transplantation in Bihar, middle class family or patients, many patients, or they are of low class family, they are coming of low class family, but they cannot afford 20 to 25 lakhs. It is a very big amount for them. So if we can cut down by, as Satish had told, with the help of PM care funds and CM care funds, if we can cut down the cost, then definitely it will be a success. Then donor is a big issue because definitely the family, when a young patient dies because of any RTA or something like that, the family is not very much aware, they are not very much counseled, they are afraid to let the body be donated. So we have to create awareness among the population, awareness among mass population for the benefits of benefits of donation. And definitely liver transplantation is a complex multidisciplinary approach we need, in which we have dedicated transplant doctors, which we definitely have right now sitting among us. Then we will have nurses, we will have staff teams, we will have radiologists, we will have anesthesiologists, we will have interventionists, we will have pathologists, and many more. And definitely government support is very important because everything has to get done with the help of the government, with the permission of the government. So all these factors, if we come into play, and definitely we are trying our best, and we have collaborated with BLK Max Hospital, and we hope that we can provide the citizens of Bihar a very good place where we can provide them with the benefit of liver transplantation, which is not carried out in Bihar at a very low cost and with a very good outcome. Thank you.
थैंक यू वेरी मच डॉक्टर वैभव। अगर आप में से कोई सवाल पूछना चाहता है, कुछ Now I would like to ask Dr. Vipin and Dr. Pankaj to sum up the session. अच्छा, सवाल
Sir, coming to first question, the maximum age for consideration of liver transplant is definitely not bound that it is a fixed age beyond which we cannot do liver transplant. Liver transplant is also been carried out in persons more than 70 years, also it has been carried out, but 60 to 65 years we are taking as a that we will have a very good outcome up to 60 to 65 years, and if in few cases we can consider up to 70 years also. And yes, sir, definitely. And sir,
I will take this question. So, I'm surgeon, so maybe I can better answer this question. So, age is just a number, sir. It's far as any surgery is concerned that applies to the liver transplant. So we have done transplant in the 76-year-old patients also, and in previous registration we have done in the 80-year-old. It has been a successful liver transplant. So it is the patient's fitness which is more important. If the patient's pulmonary condition, cardiovascular condition, and basic general fitness is good enough, yes, it can be transplanted. And then coming to the lowest case group. So again, the transplant has been done in a 1-day child also, and we have done transplant on a 3 months old kid also. So again, that is not a problem.
What were the indications for doing liver transplant?
Okay, I'll be a little louder. It was a case of acute liver failure, sir. Due to some diagnosis. And the case that we did not 3 months old child was really affected. It's a congenital condition where bile ducts are not formed. So the kid is born with jaundice, which is not relieved. And there's another procedure called the side water introscopy that has to be done within 3 months of the time. Then it is successful. Otherwise, you have to go into the liver. So kid is still doing well, sir.
Thank you. Now I would like Dr. Defin and Dr. Pankaj to take some of the session.
On behalf of BLK Max team, I would like to thank Dr. Satyajit Kumar Singh for this warm opportunity and giving us such a platform where we can, as a team, come and help the patients who are suffering from liver disease. I am also thankful to the various specialty doctors and other guests who have come and be here and listen to us patiently and share their thoughts. As we all know that before concluding that liver transplant is just the surgery to change the organs. The whole purpose is to improve the quality of the life of the patient, especially if it is done in a timely manner. As we all know, the stress of surgery is big, so the whole workup depends on how fit is the recipient. Sir, again coming to your question only. So the stress of surgery can be tolerated by the patient, both the donor and the recipient. We then take the fitness for both donor and recipient by performing various tests, whether it's cardiac, renal, and other fitness tests. Only then we submit them for the liver recipient and donor. So that's a big process, and it takes around 2-3 days to undergo all the tests, including radiological tests. So again, I'm thankful to everyone, and thank you Dr. Satyajit Kumar Singh again for inviting us to such a beautiful city, and we hope that our association will in near future will bring a lot of good health to the patient of Patna and Bihar. Thank you very much.
As a cardiologist, I don't have much to say about liver transplant. but I feel proud as a part of Untitled that we are going to start liver transplant program along with the best in field BLK hospital, and this is going to happen first time in Bihar. So I wish all the success to the team, and from our side we will be around there for support and whenever any cardiological help is required. I wish to thank Satri sir for all the support to everyone, for all the departments, and he has energy and to grow and provide everything possible in state of Bihar. Thank you.
I would like to also answer an answer question which he was asking regarding acute contraindication if the patient is in severe sepsis or the patient has invalid sepsis, then definitely outcome is going to be very poor. Then if we have patients having metastatic malignancy, if the patient is having severe cardiovascular disease like severe portopulmonary hypertension, is there. These are few things which we consider before taking over transplantations. And sir, last third question was that sir, hepatitis B, sir, the patient is presently having some injectable viral load, and the patient is a prospect of liver transplantation. Then we try to reduce the viral load as much as possible before the surgery. Yeah, so if the patient not before, then post-operatively we start the patient on antivirals. Sometimes we also give one antivirals, and after that we also give them globulin. Immunoglobulins we add, sir. For few weeks to months we add immunoglobulin, and after that we add dual antivirals, and then we transfer shift out to single antivirals.
Thank you very much, sir. और मैं चाहूँगा डॉक्टर विभा मैम प्लीज डॉक्टर विपिन और डॉक्टर वैभव को आप फेलिसिटेट करें. मैं उनको के साथ जोरदार तालियां होनी चाहिए प्लीज एवरीवन. और डॉक्टर विपिन और डॉक्टर पंकज को एक साथ यहाँ देख के वो गाना याद आ रहा है, दर्द दिल दर्द जिगर. थैंक यू वेरी मच सर. अब हम अपने अगले सेशन की तरफ बढ़ेंगे. For the next session, may I please ask Dr. K.N. Singh sir और Dr. Amit Singhal के इस सेशन को शेयर करें. जोरदार ताली के साथ स्वागत करेंगे प्लीज. डॉक्टर के.एन. सिंह एंड डॉक्टर अमित सिंह साहब प्लीज. And our next speaker is Dr. Abhilasha. 5 साल का अनुभव HPV सर्जरी और लीवर ट्रांसप्लांट में. एक्टिव पैनलिस्ट हैं, पार्टिसिपेंट हैं मल्टीपल कॉन्फ्रेंसेज में और मल्टीपल पब्लिकेशंस इन द जर्नल ऑफ एवोल्यूशन ऑफ मेडिकल एंड डेंटल साइंस. जोरदार ताली के साथ स्वागत करें डॉक्टर अभिलाषा.
Good evening, chairpersons, esteemed guests, and ladies and gentlemen. I'm Dr. Abhilasha. I'm very grateful to Dr. Satri sir for asking me to be on this podium and speak among such distinguished guests. I have very humble experience in HPV surgery. I finished my fellowship from CMC Vellore in year 2019, and prior to that I have done senior residency in hepatobiliary surgery, and even post-fellowship I have done some residency. So, sir asked me to speak about my experiences in hepatobiliary surgery. My qualification, like I said, I started as a senior resident in the department in 2015 after finishing 2 years of senior residency in general surgery from Maulana Azad. And after doing 2 years of senior residency, I started my fellowship program, which was through an entrance examination. I qualified and then finished the fellowship. While doing my fellowship, I did a 1-month observership in HPB Oncology at Tata Memorial, Mumbai. And again, post my fellowship, joined as a senior resident in the department. Left Vellore in 2020 and been here in Patna from September 2020. Met Sir in September, asked him if you have something for me. He said, wait, I may have something for you. And I waited patiently for almost a year and a half. January 22, Sir called me and said, we may be starting a HPV and liver transplantation program. And obviously I jumped with joy. And I'm really looking forward to this program, working with Dr. Abhidip's team. My teachers, I would like to mention their names because they've played a very pivotal role in whatever I've learned so far. These are from CMC Vellore, Dr. Sitaram, Dr. Philip Joseph, Dr. Frederick Vyas, Dr. Ravish, and Dr. Manva. As a part of the HPV and liver transplant team, we used to see about 9,000 to 10,000 patients per year in the OPD, which included new and old patients. We operated in about 500 to 550 patients per year. This was mainly because we had very less operating time. Hepatobiliary surgery became a separate department only 10 years back, and we were not given enough OT time because CMC used to have many theatres and we were giving just 2 operation theatres per week. Out of which maximum cases were gallbladders, about 200 to 230, which included laparoscopic cholecystectomies, radical cholecystectomies, open with frozen sections. We used to do about 100 operations of bile ducts, which included choledochal cysts, strictures, choledocholithiasis, hepatolithiasis, and malignancies. About 60 to 70 Whipple's operation in a year, about 50 major hepatic dissections, which included dissections for HCC, intrahepatic cholangiomas, hilars, cystic neoplasms of the liver, hepatolithiasis, and hydatid cysts. And also, we used to do about 10 to 15 cadaveric donor liver transplantation at our center. We did not do too many live donors. Actually, during my tenure, we just did about 2 live donors. One was a child, operated at the age of 1 year. He was from Bangladesh for biliary atresia, failed size. And another was an adult with hepatitis B related cirrhosis. He did not do well, he passed away. As far as my experiences and other research publications, I did a research as a trainee there, which was on Whipple patients. We were trying to find out the efficacy of drain amylase content on post-operative day 1 to predict the incidence of clinically relevant pancreatic fistula. And with this study, we wanted to establish the accuracy of drain fluid amylase. We all know, the ones who are operating on pancreas and doing Whipples, that drain fluid amylase done on day 3 tells us about what are the likely chances of developing a post-operative pancreatic fistula. So we decided to do this study based on a study by Diglio et al., where they did a meta-analysis and proved that day 1 amylase level can predict the incidence of clinically relevant fistula. So we had about 140 patients in a span of 2.5 years, and my study basically categorized patients as low risk, intermediate risk, and high risk based on the drain fluid amylase cutoff values, which was less than 300, between 301 to 5,000, and more than 5,000 on post-operative day 1. And subsequently, we used to send amylase levels at day 5 and other days, and the conclusion was that less than 300 had a very high specificity and high positive predictive value, making it a good cutoff value to rule out clinically relevant fistulas, whereas more than 5,000 had high specificity and it was a good cutoff value for to predict increased risk of clinically relevant fistulas. However, we could not use either of these values as a screening test because they had low sensitivity. So we discussed this amongst our team and we tried to find out the reason why we had this kind of bias, and we realized that because there were various surgeons operating, maybe some of them had practice of washing the peritoneal cavity with a lot of fluid post-op, and maybe because of that the amylase value used to get diluted. Other researches that I have done as a trainee and senior resident is merits of enhanced recovery after surgery, ERAS protocol following Whipples, which was published in JDCR in November 21. Also, we did a study on gallbladder specimens where we used to stain it with methylene blue dyes immediately after removing the gallbladder, post-cholecystectomy. Any way we remove the gallbladder, whether open or lap, and we used to stain it with methylene blue dye. And if it took this stain, we used to send all the specimens used to go for histopath, but we saw that the specimens which stained very well with methylene blue had high incidence of malignancy. And this has been sent for publication still in the process. There were various posters and presentations at various conferences. This one in particular I wanted to bring to your notice. Sorry, one second. Pointer. Pointer, one second. So, नहीं होगा क्या? कोई बात नहीं. So this was a study I did at my center where I actually happened to come across this entity called mucinous cystic neoplasms of the liver by chance, and we had about 15 cases of these mucinous cystic neoplasms, and I compared them with another entity which is known as intraductal papillary neoplasms of the biliary ductal origin, and where we saw that the WHO classification initially classified them as biliary cyst adenoma or adenocarcinoma, changed the classification system, and MCN was recognized as an entity where there was ovarian stroma present, and intraductal papillary neoplasm was when there was communication with the biliary tree.